5, 4, 3, 2, 1. We are live.
Okay, thank you. Hi, this is Dr. Sandeep Patwardhan, pediatric orthopedic surgeon, Sancheti Hospital. On behalf of OrthoTV, we are doing this Ortho School series where today with Isha Tambolkar, I am going to teach you about metabolic bone diseases in children. And to introduce that, basically what you need to know is what is the calcium and vitamin D metabolism in a growing age and how it affects the growth of bones and what are the diseases that are likely to be caused by deficiencies of certain vitamins. So in your exams, you might get this as a long question or a short question. It could be either vitamin D, rickets, the role of vitamin D and metabolism of vitamin D and its relation to rickets, and or a short note on only rickets. So let me just explain to you what it is all about. Now, if you see, every bone has got a growing end. You know that is called as epiphysis. The epiphyseal plate requires, it is under the influence of hormones and it requires weight bearing for development and growth. Along with that, it needs proper intake of calcium, vitamin D, and phosphorus. Right? If there is any kind of a problem with vitamin D or phosphorus, you can end up having a disease pattern which is called rickets. Now, when you hear the terminology rickets, osteomalacia, osteoporosis, osteopenia, right? You must know what is the difference between all of these. Rickets means poor mineralization of immature bone, which means if there is improper mineralization of a growing bone, it leads to some changes, which is called rickets. The same disease, when the growth is finished, is called osteomalacia. So when you are a young adult or as an adult, if you have poor mineralization of bone, which means unossified bone, which leads to weakening, it's called osteomalacia. When you have osteoporosis, in osteoporosis, the problem is not with mineralization, it is with density, right? So if you have 1 square inch of bone, and if it is supposed to contain 1000 osteonal units, which are normally mineralized. In osteoporosis, you may just have 500. But whatever osteonal units are there in the bone are normally mineralized. So it's not a problem of mineralization, it's a problem of per square inch, the density of bone has decreased. And that is what is osteoporosis. Now, all these conditions will lead to decrease bone density on a plain X-ray. So when you take an X-ray and you find that the whiteness of the bone, which is because of calcium content, is reduced, that is called osteopenia. So osteopenia is really a radiological term. It is not a disease. In any condition, if you see that the bone mineral density looks low, you will call the X-ray showing osteopenia in bones. Okay, osteopenia may happen because of reaction, hypervascularity, tumors, anything. Okay, but osteopenia is not a disease, it's a radiological term. Osteoporosis is a disease which happens in older age. Osteomalacia is poor mineralization of bone, which happens after skeletal maturity. And rickets is when you have poor mineralization in the growing age group. You understood that, Isha? Yeah.
Yes.
Okay. So moving from there, other than minerals, what is there in bone is scaffold. The scaffolding of bone is on collagen. So just imagine bone structure as being as a concrete wall of a building. You have those iron girders, and then you have those cement and concrete material in it. So the iron girders are actually like collagen tissue, and the concrete and the cement and the bricks and the mortar is what is calcium phosphorus, right? Which are the building blocks. Okay, and in between there is protein, that is collagen. So sometimes you can have genetic conditions where this collagen is defective. That leads to weakening of bone, and that condition is called osteogenesis imperfecta or brittle bone disease. So that is sorry, that is different from rickets, right? Now, in rickets, what happens is that you must realize that there could be deficiency of calcium, vitamin D, or it could be deficiency of both calcium and vitamin D, or it could be deficiency of phosphorus. Now, this integration into bone, conversion into bone of calcium and phosphorus into matrix or mineralization is under the influence of vitamin D, parathyroid, thyroxine, and other hormones. Okay, including growth hormone. But the commonest cause of rickets is vitamin D deficiency and calcium intake deficiency. So that is what causes rickets. So you should understand vitamin D metabolism. Vitamin D is naturally created in skin under the influence of sunlight from 7-dehydroestrogen or cholesterol. You know that from the skin on exposure to sunlight, natural vitamin D can be formed. Oral intake of vitamin D, which you take, is normally the precursor vitamin D, and that is converted to 25 hydroxy and 125 hydroxy in the liver and the kidney. Yeah. So
Yes.
that makes it active hormonal form of vitamin D, which is responsible for calcium absorption and integration into bone. Okay, if you have calcium in the right amounts. So any liver disease or kidney disease will also affect mineralization of bone, which is why in chronic renal diseases, old age, diabetes, you will have weakening of bone, okay, or osteomalacia. In the growing age, you can have the commonest cause of rickets. If you look at rickets classification, right? The classification of rickets, I used to remember it as a mnemonic DARRU. Okay, normally you don't want to associate yourself with alcohol, but Daru here was a good mnemonic to remember. Yeah. D is dietary, A is absorption, R is renal, second R is renal osteodystrophy, and U is unusual causes. So when you classify rickets, it can be D, deficiency of vitamin D, calcium, or phosphorus. A is absorption. That means you are taking adequately, but you have celiac disease, Hirschsprung disease, or any kind of bowel disease where you may have resection of bowel being done. Any disease which will retard absorption or prevent conversion, such as chronic liver disease, gallbladder diseases, anything that causes a problem with absorption. It's not with intake, it's a problem of absorption. The third is renal. Renal means normally there is conversion, as I said, the second hydroxylation from 25 to 125, okay, of vitamin D happens in the kidney. So if you have a kidney disease which will prevent conversion, and that will lead to rickets. So that is called renal osteodystrophy. The other renal cause is where you have genetic deficiency, where you have renal tubular acidosis or RTAs. Now that is a pediatric condition where there is a problem of reabsorption of bicarbonates or amino acids in the distal tubules of the kidney. Where filtration happens, the kidney also has a function of controlling the soda bicarb, the metabolic balance of the blood. So the pH of the blood can also be regulated because of the amount of soda bicarb or bicarbonates which are excreted or reabsorbed from the distal tubules. So phosphorus reabsorption, bicarbonate reabsorption, amino acid reabsorption can be defective because of genetic errors. And there are various syndromes associated with that. So this automatically may cause high loss. If there is an error, there is loss of phosphorus, loss of bicarbonate, and an acidic pH, which is why the condition is called renal tubular acidosis. And you get rickets with that. And the unusual causes, which I said, is usually drug induced. If your child is under anti-epilepsy medication for some reason, it's a spastic child or a seizure disorder, and they are taking a lot of anti-epileptics, then they can have rickets. Or there is a very rare condition called hypophosphatasia, which means alkaline phosphatase enzyme is deficient from the liver, and that causes rickets. So that's called hypophosphatasia, not hypophosphatemia, which is loss of phosphorus. Now, what are the features of rickets? Rickets is clinically to be diagnosed as a lot of features are there from the skull down to the toes. And these clinical features are, everybody likes to talk and ask about them in exam, and you must mention the clinical features. So in clinical features, in a growing child, what you will get in the skull is prominence of the suture lines and frontal bossing. So that is called hot cross bun appearance. Okay, it's like a pawachi ladi. So you get deep sutures and then prominent skull bones, the parietal and the frontal bones. So you get a hot cross bun appearance of the skull. Then you can have coming down poor dentition. Then you go down to the rib cage. On the rib cage at the costochondral junction, which is paracentric, you will get rounded beads. Okay, that is called rachitic rosary, like the rosary which the priests have, or jap mala as we call in Marathi. So you'll get beady appearance at the costochondral junctions. Now the peculiarity of this is they are non-tender, rounded and smooth. Okay, you also get this kind of a rosary in scurvy. But in scurvy, it is because of costochondral dislocation. And that is sharp and tender. Whereas rosary in rickets is rounded, bead-like and non-tender. Okay. So that is called rachitic rosary. All this is because of accumulation of unossified osteoid. So you have cartilage trying to make bone, but there is no mineral in it. So this is just soft bone which deforms on pressure, right? So the pressure of breathing of the diaphragm causes a transverse sulcus called Harrison's sulcus. So in the lower half of your chest wall, you can get a transverse sulcus in rickets, which is called Harrison's sulcus. In the spine, because of softening, you can have kyphosis. That is called a rachitic cat back, dorsal kyphosis. Then, because of low tone of the abdominal muscles, because of hypophosphatic, because of rickets, you will get bulging belly or pot belly with hyperlordosis in the lumbar spine. Okay, so that's called pot belly because of hypotonia. Then in the pelvis, you can get a more square pelvis. And in the X-ray, you might see looser zones or pseudo fractures. Again, unossified cartilage is seen like a fracture, a loosened line. These are also called Milkman's fractures. Then in the hips, you can have coxa vara. In the knees, you can have genu varum or genu valgum. That means bow legs or knock knees. Along with that, you can have tibial torsion. And in the ankle, you have widening of the malleoli, which is called double malleolus. Okay. So all these, Isha, are multiple signs from top to bottom of having rickets. Sometimes you may have some of these or all of these. Now, the second peculiar thing you must understand is that if along with rickets, you have protein energy malnutrition, which means there is no energy or there is no protein also, and the child is not growing at all, you will not see rickets. You will start seeing rickets when you correct the PEM, when the child resumes growth. So rickets is always a change seen in a growing skeleton. If there is no growth, you will not see rickets despite deficiency. All right. So these are the clinical features of rickets. So they may present to you with bow legs, knock knees, torsion, deformities, but usually all of them are painless. The minute you get painful rickets, you must suspect renal rickets. So stunted growth and abnormal deformities, asymmetrical deformities, and tender bones with pain is a feature of renal rickets. That is what you should know. What are the investigations? The investigations that you normally do are calcium, phosphorus, alkaline phosphatase. Always you will find blood calcium is usually normal because we need normal level of blood calcium to survive. Otherwise, you will get cardiac asystole. So what happens is that the body will take out calcium from bone and put it in blood. But the blood calcium will always be maintained. Very rarely will you get hypocalcemia. You can get hypocalcemia, but if you get hypocalcemia, you will start getting tetany. That means involuntary spasmodic contraction of skeletal muscle. Right? So that is extreme rickets and hypocalcemia. But most of the times the calcium will be normal. The phosphorus can be low in case of hypophosphatemic rickets, and alkaline phosphatase is always raised because whatever alkaline phosphatase is supposed to ossify bone is released into the blood rather than being utilized for bone formation. So a high alkaline phosphatase will always tell you there is active rickets. Along with that, if you suspect renal rickets, you must do urine pH and arterial blood gas to look for bicarbonates and the pH of blood. Unless you correct acidosis, you will not be able to correct rickets. Right? And the final thing is X-rays. So on X-ray, you will see the classic changes of rickets, which is metaphyseal, cupping, fraying, splaying, and irregularity. So the soft osteoid on weight bearing becomes funneled or cup shaped. So it's called as cupping, fraying, splaying, and irregularity with osteopenia, as I said. Okay. Now, what is the treatment of rickets? The treatment is to correct the metabolic imbalance. Metabolic imbalance has to be corrected first by giving supplementation of vitamin D and calcium. So what you will do is something that is called as STOS regime. STOS regime means you give a loading dose of 6 lakh units of vitamin D stat. If the child does not have absorption problems, an oral dose is adequate. So you give 6 lakh dose loading and then repeat alkaline phosphatase and X-rays after 6 weeks. If you find that there is a provisional zone of calcification which has appeared on X-ray and your alkaline phosphatase levels drop down, then continue with just plain calcium and daily supplement of vitamin D of 200 to 400 units. Okay, and stop the high dosage so that you give maintenance and then the rickets can get cured. If after 6 weeks of oral there is no change, it could be an absorption problem. You can give injection of vitamin D 6 lakh units. Some people prefer to give it in rather than a single dose, they will give 50,000 units every week for about 6 to 8 weeks. So you can give it in the form of sachet, drops, or powder, whatever formulation you think is appropriate for the child. But you load with vitamin D and then look for changes and then give maintenance. If the child is resistant to this, there can be renal rickets. So then you will need to check for acidosis and then start soda bicarb. If it is phosphatemia, you will need to give phosphorus solution. So these are genetic defects, and then bicarbonates and phosphorus solution may have to be taken lifelong. All right. And then if the child is still resistant, there are genetic conditions where you can have end organ insensitivity. That means you are giving adequate vitamin D, but the bone receptors don't respond and there is no bone formation. So that is called vitamin D resistant, or in extreme cases, vitamin D dependent rickets. Those are again special cases called VDDR or VDRR, vitamin D resistant or vitamin D dependent rickets, and very high doses of vitamin D. Or you need to give then active form, rocalcitrol. That is 125 dihydroxy tablets need to be given on a regular basis, because there is no conversion in the liver or the kidney, or there is an end organ insensitivity. Right? So the most of the management of rickets remains medical to correct the metabolic bone problem. What about the deformities? If the child is young and has deformities, with growth and correction of the metabolic problem, the deformities will usually correct themselves by 6 to 7 years of age. If they don't correct, or on clinical examination, your intercondylar distance for bow leg is more than 10 centimeters at 5 years, or intermalleolar distance is more than 10 centimeters at 5 years, we may need to do something called as growth modulation. Earlier, we used to do bone surgery called osteotomy to cut the bone and make it straight. Now we put small clips on the growing end of the bone, lower femur or upper tibia, and then stop growth on one side and allow growth from the other side. That's called growth modulation. Like braces you put for correction of bad teeth, you can put clips on the bone and cause change in the angle of the leg. So you can do growth modulation in the growing age to correct such deformities. If maturity has been achieved, you will need to cut the bone, which is called osteotomy, and then correct the deformity. But very often with correction of the medical problem, you will get correction of the deformity spontaneously by 7 years of age to 8 years. You should be patient and counsel the families. And surgery is reserved only for resistant cases and extreme deformities. Usually there are very little complications of rickets other than these deformities, which are easily correctable. The only thing is renal rickets is a lifelong disease and needs to be treated as such. Second is chronic kidney disease, which causes renal osteodystrophy, will have raised BUN and creatinine. It's a kidney dysfunction. And those children will need dialysis, and they may need a renal transplant in case their kidney has failed and they are going into uremic status. So you must correct the primary medical problem before you think about medical management of rickets. That is important. So treat the primary cause. And the other metabolic problem in children is called scurvy. Scurvy is now very rarely seen because most of our foods are fortified with vitamin C, and we do have good sunlight and exposure to citrus fruits. So lime, oranges, all these are very well seen, very well consumed, and there is hardly any scurvy seen nowadays. But in neglected kids like cerebral palsy who are bedridden, we still see scurvy. Now, scurvy is because of vitamin C deficiency. Vitamin C is important for endothelial lining formation and also bone formation. So what happens is that there is hemorrhage, brittleness of vessels, endothelial lining can cause brittleness of blood vessels and bleeding. So the children with scurvy will be having bleeding gums, swollen red bleeding gums. They can have petechiae on small injury, and they can have bone pains and tenderness on the bone with large subperiosteal hematomas which ossify later. So on X-ray, you will see an expansile lesion with a thin rim of calcium deposition. And the epiphyses look osteopenic with a circular ring-like sign called ring sign of Wimberger. And you can have something called as corner fractures. Because of these subperiosteal hemorrhages at the epiphyseal end, you can have small cornal fractures where new bone is formed, and these are called Pelkin spurs. So there are peculiar radiological findings which are seen. The ring sign of Wimberger, the Pelkin spurs, and subperiosteal hemorrhages with calcification, and bleeding gums, petechiae, bruising, easy bruising, and bone pain and tenderness. And they can have scorbutic or rosary because of costochondral dislocation, which is very painful. But fortunately, like I said, we don't see scurvy. Scurvy was seen more in sailors who went out on sea voyages and they had no access to fresh fruit or lime. And they all developed scurvy and bleeding, and that is why all those pirates and all, and the sailors used to have a lot of scurvy changes, and just vitamin C was the treatment for that. So even now, giving 1 glass of lime juice will take care of the problem, and hardly any surgery is needed. Everything ossifies once vitamin C is restored. Nothing more needs to be done. So these are the metabolic problems that you see in children, and I think this much information should be good enough for you to write answers.
Yes, sir.
And you can read more about it.
Yes, sir.
Other than that, genetic conditions like epiphyseal dysplasias may mimic rickets on X-ray, and you should be aware of dysplasias, which are genetic conditions. All right.
Yes, sir.
Advanced imaging is not needed, and that is all there is to metabolic bone diseases. All
Yes,
right.
sir. Yes, sir.
Okay.
Thank you, sir.
So Rishi, you can stop recording. Okay, Isha. Bye.
Yes, sir. Bye. Thank you, sir.
We'll see you on Friday with something else.
Yes, sir. Thank you.
Okay, bye.
Bye.